Hi, thank you all for attending this presentation or webinar with me this evening. My name is Sabrina Leonard. I'm currently a second year PA student at the University of Arkansas for Medical Sciences here in Little Rock. I'm currently doing all the things it seems, but specifically I am working with Osmosis from Elsevier, which is an online education platform that creates like bite-sized videos for students to learn healthcare content, especially as they're transitioning into a more clinical frame of mind. So, Osmosis offers a health leadership initiative. It used to be yearly, but I actually had messaged them when they invited me last year. That I could not commit to doing an entire year. And so now they offer semester um, uh, cohorts. And so with that, we actually just get to pilot in, new software. So I will show you guys some very exclusive software that I'm getting to use with Elsevier. And if anyone knows anything about like publishing, Elsevier kind of locks down all of their resources. So you really can't find them without purchasing them. And so this platform was a really great way for me to really kind of see the expansiveness of Elsevier and everything that they offer through the Osmosis platform. So without further ado, we'll go ahead and get started. The topic is Think Clinically Patient Presentations. And so, just to highlight a little bit about Osmosis and their mission and vision and values, it was created by two medical students at Johns Hopkins years ago. They noticed that many of them were doing what I was doing. You sit in class all day, you lose your attention span is very short, and you lose your train of thought. And so then when they got home, they were looking for videos and scanning YouTube to try to find information in a shorter version on what they spent hours learning. And so they created Osmosis. Many of the people who created Osmosis also work for like Khan Academy. But some of their values are imagine more, reach further, open your arms, start with the heart. They really just cared about the content and the quality of the content that was being put out there to make sure it was like easily digestible. And my program at UAMS actually offers Osmosis to all students throughout their time as a PA student. And so I heavily used Osmosis in my didactic year because, again, my attention span was short. And so I would go and watch the recap of a video. If I didn't have the whole 15 minutes to watch it, I would watch the recap, which was usually 3 minutes before a lecture started. So I had a good idea of what we were going to be learning. And then I would always do the little three questions at the end just to make sure that I had a solid foundation for the content that they just presented to me. One thing about PA school, we have to maximize our time because, we're there all day. So if you're in class from 8 to 5, and then you're also required to do volunteer engagements after school on the weekends, and if you also have other commitments outside of school, it makes it very tough to study all the time. And so, Osmosis is a really great way to take advantage of some of the resources that are out there. They also, like this program, you'll get 6 months free. If your institution doesn't offer it, you can just apply for this program. But also, they have like a test trial where you can get 2 and sometimes 4 weeks free. But to go ahead and get started, I chose this topic mostly because again I'm in my pediatric uh, clinical rotations, and I got my behind handed to me because something just happens when you are in a room and getting the history and physical and just trying to get the HBI so you can then therefore present. And something just happened where I was getting lost in the translation. And the attending, this was my very first time presenting to an attending, even though it was my seventh rotation. So what happened historically is, I have worked with attendings, but sometimes they may or may not want you to develop this skill. And so this skill isn't something we spend a lot of time on in the traditional didactic setting of the classroom. It's just something that people expect you to pick up over time as you do it more. But as a PA student who has had a lot of clinical rotations with medical students, they kind of get preference sometimes, and that's not to have any shade towards them, but we have to be our own advocates when it comes to what our experience is as a student and how we are going to be expected to develop some of the same skills that they have as medical providers. So I have this poll here, and you guys can come off mute. You can use the chat box. I want this to be a very interactive conversation. But I just wanted to kind of get a pulse to see how you guys feel about patient presentations. If you've had done them before, what your idea about them is. So what part of the presentation trips you up the most? Is it organizing all the info in a logical way? Is it making a solid assessment and plan? Is it speaking clearly or confidently under pressure? Or is it forgetting details while trying to present? And you can use the chat. You can come off mute. Cyan said speaking clearly and confidently. Uh, yeah, sometimes you don't know that you're going to be a public speaker when you enter PA school. And that is actually one of the biggest like social fears that people have is public speaking. And so this is definitely something that a lot of people don't necessarily look forward to. Um, for me, it was definitely trying to organize the info in a logical way and forgetting like details. But it is a very systematic approach that we will take that we kind of learn as a whole in PA school. So just to dive right in, the meat of this conversation is going to be about how to give a good oral presentation. It should only take about maybe 10 minutes of just, delivering this content with you all. But my biggest thing is to show you some of the resources that I've been using that helped me personally develop this skill while I was on the pediatric rotations of not being able to give a good presentation and literally being called out and threatened to, contact my director of my program to, transitioning by the end of that rotation that resulted in a job offer just from, attendings being so impressed with me in the sense of how well I was able to present. So it really goes into, you being your own advocate and you seeking out those resources because when I, shared with my, clinical coordinators about my experience of not having developed this skill, it was just met with, encouragement, of course, like, oh, I'm sorry that happened to you. Definitely take this as a learning opportunity. But it really wasn't anything practical that I could use to help me still develop the skill. So fortunately, Osmosis had a short, like 8-minute video that I watched, and I was able to get the foundation of what I should be doing so that I could, formulate this information in a way to present it. Because it's not just reading your HPI to them, that's not what they want. And so, even though I saw people doing that, that's still not the way to do it. So, I will present this information in 3 easy steps. This was kind of adapted from Osmosis and the steps that they present in their video. But the first step is to set expectations. And so one thing I've learned in PA school is that everything we do should have a purpose. Every question we ask should have a purpose. If we ask somebody if they are vaccinated, we need to know what are we looking for if they're not. What is that going to look like? How is it going to present? If someone got the flu shot or they didn't get a flu shot and now they're presenting with a viral infection, but it hasn't gotten better, it matters in the timing. So when we're setting those expectations, it's because there should be a solid clinical foundation behind those questions of, well, if it's not this, then that. So just to dive right in, with your one-liners, we are going to set the tone for the conversation. We're going to prepare our audience for what we want them to know based off of the assessment we've gathered while we were visiting with the patient. So we need to answer the questions like, who is the patient? What brought them in? So usually their chief complaint, but also any context that matters right now. So this one is a little, like I always laugh because I tell people like common sense isn't so common. It's only common to you, right? It's only common to the people that do this every day. But as students that are, diving into this new world, we don't necessarily know what's pertinent, what's not pertinent. So we really got to train ourselves during this time to be able to think clinically about like what is actually pertinent. Um, and so when we are, presenting a patient saying, oh, well, I have a 3-year-old male with a cough and fever, what does that mean? How long, when did the fever start? Was it 3 days ago? Was it 3 weeks ago? So that's going to help tell me, like, is it more of a viral thing? Because we know viral infections typically last 3 to 5 days. That's what we expect, right? Versus if it's a bacterial cause, typically they're going to have this longer course of fever. So that's why we always tell them when they are coming in that 3 day window, hey, do this, do that as far as the supportive measures. But if it's not getting better, if you have a fever for more than 5 days, because we're setting them up for success to know like this should get better. Right. And so we as the clinicians who are setting the tone for this conversation, not only with our patients, but also with providers that we are presenting this case to, we have to set the tone. So everything we say matters, but it has to be in a real concise way. So again, the context matters. So I was really trying to think about a way that made sense to me. And so I think with all of us now being, in a graduate professional level of training in our education, we all should have done book reports at some point in time. So giving a patient presentation for me was very similar to giving a book report. We used to have like parties when I was little in primary school, but when you give a book report, there are main components. There's the author, the main characters, the title, the setting, like where this happened and occurred, and then that plot. So that plot is always going to be in a chronological sequence, right? Because that's how we organize things. But what happens is in the room when we're talking to patients, they may not necessarily give it to you in a chronological way. So you have to then be the person that filters this information out and put it in order so that you can present it. Right. And so that's where I was getting caught up because the patient was just giving me all this information and I really didn't know what to do with it. But then I was trying to present it and it just wasn't making sense. So you really are going to be trying to tell a story in the sense of a book report. So you have the patient, you have their chief complaint. Oh, a 3-year-old male with right lower lobe pneumonia, if that is the setting of, hey, they were actually already diagnosed with pneumonia. So you don't have to take them back to the very beginning. You're going to take them where we are right now. Or if they have been treated for pneumonia, they've already finished their antibiotics, because again, you're setting the tone for what should we expect. Again, you're always kind of looping back around to what we should expect. So if you've taken all your antibiotics and we are now just following up to make sure you're better, we expect you to be better. But if you're not, that's what we have spent our time doing as far as our training and the analysis and the review of everything that's happened. When I learned about patient presentations, another way to look at it is you have people that report the news, but you also have people that interpret the news. Or the weather to present it to people so that they can prepare. So that is the same thing that we're doing. We're analyzing everything that has happened because that's what they pay us for. That's what we're paying for this education to be able to do is analyze what has happened, because anybody can just report and say what happened. This is a skill that anyone can learn as far as that part. But the most important piece is like the assessment and plan. But if you can't get past the first part of presenting the subjective and the objective data, then you will never be able to appropriately make a concise assessment of what has happened and a plan for how we're going to address it. So to my next point, again, feel free to use the chat, come off of mute. But when someone asks you to present the patient, your first thought is what? Yes, I got this. Can I have 5 more minutes to organize my thoughts? Do I need the whole HPI or just the highlights, or you just panic and just purely panic? I definitely did all of these things. I was really big on writing everything down. Like that was my, process of trying to like put it in that systematic approach of the Socrates or the locates model, which are mnemonics that we use for HVIs and when we're actually seeing patients. But something again still happens where you are expected to organize that information and present it. So, whatever your first impression is, there's never ever going to be enough time. A lot of attendings, you will meet people with different personalities, and they are ready to work as soon as they walk in the door. Versus some people may be a little bit more relaxed, and so as PAs, we obviously have a lot of flexibility of shopping around to find a space that feels right for us. But you will have to find your groove. And that just comes in time and practice. So I would definitely just say, be nice to yourself, give yourself some grace while y'all are trying to learn and develop this skill. As far as timing, YouTube has a lot of great just patient presentations. I like to pause those videos and kind of give my own version of it and then listen to what they would say and just try to align myself with how it was done in the video. But one of these resources that I'm going to share with you all in a moment, you can actually record yourself and listen to yourself. And the ClinicalKey platform with Elsevier will actually interpret your presentation for you with the use of AI. So that's pretty great. All right, trucking right along. So our next step after we set that expectations and we are now going to present a story. This is step 2. So just like I was saying in that book report, everything has a cause and effect. So we're starting from the beginning. This is putting everything in that timeline, right? So if they had a fever for 2 days, what were they doing 2 days ago? Like when were they last well? So we can kind of again set the tone, set the frame of mind of, hey, they were fine. They just came back from a trip or whatever. So we can kind of um, narrow down what may have caused, these symptoms because we know about infectious disease processes based off of certain areas of the world. They have certain incidences of certain infections, whether it's malaria or certain strains of like ticks and things like that. If they have a bite or what have you, we're trying to get like where this began to bringing us to right now and presenting that in a short little blurb of a one-liner. Again, that patient is a 3-year-old male who had a fever that started 3 days ago. He just got back from, camping with his family. That's that mindset of, oh, camping, ticks, Lyme disease, or rickettsia, Rocky Mountain spotted fever. So that is why it is so important that we present this information, because there's an assumption that we all know the same things. And so your attendings don't know what you know, right? And as a student, you want them to expect you to know things, right? Because you're smart. We're smart, and that's why we're here. But again, everything you say has a purpose. And so if you're going to be setting the tone, you want them to be able to easily follow you. And that's how you build your confidence. That's how you also advocate for like autonomy and being able to like fly, because you want to be able to practice to the full extent of your training. So we're starting from the beginning. We're setting up the timeline of when the symptoms started, what changed. Oh, they had a fever, but now it stopped, or they had diarrhea and it slowed down, or it's picked up. Like, how are they transitioning or progressing along? And you prioritize what's relevant. And so this is really going to be what pushes your assessment further, because you are going to present the things that are going to eliminate some of the big issues. Like if somebody has chest pain, we definitely want to rule out, if it's an MI. So how long have they had this chest pain? If it was for, one day versus 3 months, it's probably not an MI, but we still can't rule it out, but we still want to put that out there. So that's why the timing matters. If, we are given a history, this and that, and oh yeah, labs, you are bouncing all over the place. So that SOAP format that we write our notes in is the same format that we should be, it should be how we present these patients. So we give the subjective, that one liner of the patient is, this, he's complaining of this or she's complaining of that. And these are the symptoms that they're having, but they're also not having these things. So we're trying to let, our attendees know, like, hey, I know we're worried about these big things, but they don't have this and this and this, and this is why. We're being able to speak to those things and keep that conversation going, so we can be concise and be able to go straight to our labs and what we want to find out. So the ultimate goal is to aim for that conciseness, be very matter of fact, because when you are with your patients, you own those patients. And it's okay. Sometimes we're going to be wrong. And that's the thing about it, but for me, that was the great thing about choosing PA. Like there's this collaborative approach. We all don't think alike. And so sometimes, we're gonna miss things, and that's okay too. Like, oh, I didn't think to ask that because I didn't realize how important it was for me to ask that. So if 2 days ago the patient felt like this, but now they feel like this today, then why is that important? And that's why they came in. So it really helps kind of hone in on some of the more urgent issues, like, if a person has like torsion or something, that timing is so important. And so we have to be able to speak to a clear cause and possible effect to their symptoms that they're having. So if we have a 67-year-old male with chest pain that started today when he was mowing the grass, what are you guys thinking? Are you feeling like it's a more acute thing, or do you feel like it's a chronic thing? Definitely, definitely acute. So when things are acute, it kind of varies, right? Depending on what it is. If it is a cardiac issue, sometimes it could be a 2 week thing, a 1 week thing. Or a GI issue if it's less than like 3 months, or sometime more than 3 months or 1 month. And so it's really important that you learn those like clinical algorithms, what the normal expectation is for some of these conditions, so that we can, categorize them. Is it a more acute issue or is it a more chronic thing? So if somebody has chest pain, obviously I need to be able to rule out some of the big things, like if it's an MI. So, what were they doing when it started? You're asking those questions with the intention of trying to hone in, like, is this actually, a major thing, or do I have time? Because when you're in the clinical practice, you're going to have to stop right then and intervene. It's not as simple as going through these steps and checking these boxes and saying, oh, yes, this, no, that. No, you may realize something and say, okay, we're going to stop our history and we're going to go ahead and get a stat EKG. We're going to do this and this and this. But depending on where you are, your attendant may want you to present this information first. So if it's an emergent thing, you have to still be quick and concise. So just be ready for it. And again, don't let that scare you. This skill set will come in time, because I learned it in my 7th out of 12 rotations. So don't fear it. Just lean into it. But in your assessment piece, after you like gather the subjective and the objective data, you run your labs. This is where your ideas and your concerns and your expectations are really the things that are fueling your analysis. What do you think is going on? Do you think it's an MI? Do you think it's GERD? What are you concerned about? Does he have a family history of anything that's saying like we cannot miss this? Has he been anywhere, or has he taken any medications that we know of that can cause like cardiotoxicity? So those are all the things you learned in your clinical training in the didactic phase that you're trying to miraculously put together. This is what is happening in that analysis piece. But sometimes people are just saying, oh, this is something you'll just develop. Well, tell me what exactly is happening that I'm developing. But I just wanted to be able to speak to that. So, and this is also the expectations. That's where your plan comes into play. So our plan is, hey, his family has a history of, mitral valve prolapse, or he used to take Rubicin, and for a history of cardiac or lung cancer years ago, whatever, or and now you're like, oh well, I need to do a further workup, and it may be as simple as consulting cardiology or what have you, but you need to be quick and ready to know those things. So you have to know your content for sure, but you have to be able to interpret it and know why it's important. All right, so last thing, after we set our expectations and we present a patient or present a story, we're going to remember the end of the story. So this is again that analysis, that assessment and plan that I was kind of speaking to. How do you want this story to end, right? Because fortunately, they're still alive, hopefully, fingers crossed, they're still alive, and we still have time to intervene. And sometimes it is that simple of life and death. It is that urgent. So how do you want this story to end? You get to shape what happens next. And so that's the beauty of being in the space where we get to be, providers. What's leading your diagnosis? What do you need to confirm it? What do you want your team to know? Like, how do we set this patient up for success to make sure they get everything they need? Everything they need to make sure they're handled appropriately, because that's again the great thing about being a PA. We get to collaborate with these people and we get to really advocate for that patient and saying, hey, I know you think it's this, but my gut is still saying this, and we're humans. That's the beauty of keeping humans at the forefront of medicine, keeping us a part of the conversation. And I tell people I trust myself more than I trust AI and chat GPT and all these different things, because I know, what it feels like to be a human. And that's not to, downplay the advances that have been made in technology and the beautiful things that can be done to embrace it into our world. But it cannot think clinically for us. It doesn't have that special sauce. And you guys have it. And that's why we're here. But we have to set these patients up for success. And so, what do we expect in 3 days of starting antibiotics? If they're not getting better, hey, is my blood cultures back yet? And so those are all the things that's keeping you in the back of your mind saying, oh, actually, they're not back. Let me check on that. Oh, they never ordered them. They never collected them. So those are all issues, right? But if we're not constantly thinking about these things and reassessing the patient and thinking about like, why are they not meeting the textbook expectations of them getting better? Because even though like real life isn't textbook, a lot of them are. Like once you start to see the trend of how people are progressing, a lot of them are textbook examples of simple things like viral infections and MIs and things like that. But you again have the power to help write the story in these patients' lives, and so we have to be good stewards of what we've been entrusted to do. Learn to trust yourself more than these computers and these algorithms that are kind of help trying to guide your thought process. Is great because they obviously have a wealth of information available in a split second. But again, we start to feel things and we just kind of have this miraculous ability to know like, oh, I have a strong feeling, can't explain it, but again, always follow your gut. You will typically not be wrong in a lot of those cases. Even when I've been presenting on patient cases, they are just like, oh, that's actually a really good catch. Because I didn't think about that or I didn't assume that because whatever reason. So you'll be surprised. All right. So another poll on a scale of 1 to I'm basically a TED Talk speaker. How confident are you with patient presentations? So I am like a TED Talk speaker. I'm smooth, polished, and ready to impress. That should be the goal, right? But I know everybody isn't there. I'm pretty solid, might fumble a bit, but I get the job done. I survive, but mostly by reading from my notes or praying for no questions. And wait, what is the soap note again? Um, so again, feel free to hop in the chat or come off of mute. Um, Cyan says she's pretty solid. So that's awesome because, everybody's in a different space in their learning. Again, for me, this was not a skill that I had developed and I was just like, oh, okay, well, I'll pick it up over time. But, we have to be very intentional about our education and the training that we're receiving. And so when I, again, was chewed out and noticed that I was not getting this skill, I learned a lot about myself. And so use your clinical rotations as a time to really develop skills that you need to be better, but also highlight some of those gaps that you may need to work on. Um, all right. So overall, there's no, secret recipe or surefire things that we can do to have just the absolute best oral presentation, but we can just follow these generalized guidelines of, setting the expectations, presenting a story, and remembering the end of the story. That's our assessment and plan. But make sure you know your patients inside and out. When you take your time to talk to them and learn all of the things that will actually serve in your HPI and your history. It will help you when you are speaking to the attendees like, hey, this patient actually, voiced this because you took the time to talk to them. I love P's because I love putting in my reports that the patient wanted to be a fireman or a police officer and really had nothing to do with it, but it just kind of reminds people that these are people that we're taking care of and not just a textbook case and a question that we're trying to get right. Um, Always be aware of your body language. Try to appear relaxed and confident. You know things. So don't let people intimidate you. I've noticed in the medical world, people love to try to intimidate and make you feel some type of way. I don't know if some people, I definitely feel like that is their goal in life is to make you cry. But others, they may not realize that they're coming off as like maybe standoffish, but I love to give people the benefit of the doubt. I don't assume anything and I just try to stay calm and focus on my presentation and not ask for, feedback. And sometimes it is not necessarily solicited and they just give it to you anyway. And so those are always the best experiences when they're, giving you feedback. Because one of my favorite foundational things as in my faith is that God chases who he loves. And so when I'm receiving criticism or chastisement, I believe that these people care about me and they want me to be better. And so if I always, stay grounded in that foundation, I feel better when it didn't feel good in that moment, but I know that they cared about me enough to tell me what I needed to do to improve. So that's pretty much it. Um, Again, osmosis has been the thing that has been my personal study tool of choice. I honestly feel like their questions are a lot harder compared to as far as like clinical knowledge when you're doing like the pants type questions and even like the USMLE step 2 questions. They don't say who can use what type of questions, which I personally like, but their explanations are pretty simplified. They have all type of resources like with the high yield notes, the case questions, but you can also like create like a plan on their website and they have recently been using the PANS blueprint to create a specialized study tool or collection of videos based off of clinical rotations, which is great. They are very lengthy and there's a lot of repetition in them. But, this is a really exciting thing that they're trying to really streamline and make it a little bit more user friendly. But if you all use Osmosis, always they welcome that feedback. Um, I had the privilege of, working in this OHLI program to try to incorporate mindfulness. I tell people my seasonal depression was very spicy during the fall. The sun wasn't out. I was on clinical rotations. I felt neglected by my faculty. It was hard, but we have to make sure we're taking care of ourselves. And me joining the Osmosis OHLI program was my way of trying to stay grounded in the things that were very personal for me. I wanted to make sure that people weren't, attacked for not knowing things. We always created a space that was welcoming and inviting to people who may not necessarily learn the same way you do. And so Osmosis has a huge platform that is honestly used mostly overseas. Only about 16% of their users are US based. So I've had a wonderful time with them, connecting with people from all over in Rwanda, Jordan, um, uh, the Philippines, just to name a few places. And with my history of working as a nurse and a patient care tech and working in the lab, I've been able to connect with a lot of people, and I'm so grateful. They're actually going to turn me into one of these cartoons just based off of some of the feedback and experiences I've had. So I'm really excited about that. I tell my family I'm famous. But if your program doesn't offer osmosis, you all can get 2 weeks free of Osmosis Prime. If you find that you really like it and you just really like this video too, you can just email me and we can try to get you an additional 2 weeks. Osmosis is going to have some conversations about this program if you're interested on May 8th at 1 o'clock Central Standard Time. But also, it also caters to nursing students. So they'll have a conversation about taking care of yourself and resilient strategies. I believe those things are transferable. But lastly, the future of healthcare and technology. So if you're worried about AI, they have a lot of conversations about that part. And so that'll be on April 17th. All right. So here is a link. While this is up, I am going to try to, oh, well, I am going to try to log into the ClinicalKey. This is what I'm mostly excited about. Sorry if that took a little bit longer than anticipated. If you have questions, feel free to come off mute or drop them in the chat. This is ClinicalKey by Elsevier. This is a tool that I've gotten to use and pilot as a osmosis leader with their healthcare initiative. And just to kind of plug in something about osmosis, like originally this OHLI program, it was named something else. It was catered to medical students, but a PA actually applied for it. And she was just like, well, why don't you guys, offer these things to us? Like, we use your platforms too. And so they restructured everything. They started inviting PAs, they started inviting nurses. And so that very intentional, innocent application is something that for me really speaks to our profession as a whole. We have to, insert ourselves to be a part of the conversation. And, some people are going to welcome it with open arms like Osmosis did and immediately implement changes. And some people may be a little hesitant, but you never know if you never try. So definitely be encouraged to put yourselves out there. So real quickly, the ClinicalKey is a software offered through Elsevier. Elsevier is a huge publishing manufacturer for textbooks primarily, but also like online resources like Osmosis. We predominantly use McGraw-Hill, which is another publishing company, and their content is pretty similar. It's good content as well. We have access to something called Access Medicine, with my institution where we can access textbooks, but anything Elsevier is pretty much locked down. You're gonna have to buy it. It's expensive, and so not to try to like sway you to do this osmosis fellowship, but it definitely offers you some great resources. And you can always renew it. They actually offer something called 3D anatomy, which is like a crazy expensive resource, but it's so amazing how accurate it is if you are in gross anatomy in that first incoming class in the summer of my program. So some of the resources you can look at textbooks. I'm just going to quickly show. So if you were looking for pediatrics as a whole, you can look at all the textbooks. You have access to them. If you were looking for something very specific, like you got books, you got images, you have videos that you can review. What I personally like is the ability to look at procedures because I don't do them every day, and so I will look up like a circumcision. And so you can find like resources to be able to learn how to do a circumcision. And then also watching videos, whether it is on osmosis, which, you know, is also owned by Elsevier. So they always plug in a lot of their resources. Um, so that's the study resources. I use it, you know, mostly again for the books and things like that. But I'm going to go back to my hub. They have a question bank. It's just board style questions. I'm not going to go into that. They also have practice exams that as a limited time user, I get to use, but I have like a diagnostic test. I'm going to do that soon. But they have given me access to just the diagnostic exam. So it is USMLE Step 1, but a lot of our content is pretty similar. So it's still applicable. But this is what I love the most is the clinical cases. So when you're out or getting ready to go into rotations, this is the bread and butter of what has really, you know, helped me develop my skills. And so you can do things by you can do things by specialty. You can do things by chief complaint, which will help a lot with OSCE's preparation. You can also sort things out by not necessarily specialty, but by system. So if you browse cases, you can look at your population, which is great. So we actually offer a geriatrics rotation. So this is great for that. And if y'all have ideas for one you want to look at, just drop them in the chat and we'll land on something. But the specialties, emergency medicine, ped, psych, the body systems, behavior medicine, GI, chief complaints. So it's a really expansive software that I think is great. I was actually having a conversation with my program director about this software. He was asking me if I felt that it could be embedded into our program, and I just really again appreciate my program, just the PA, you know, profession as a whole, because we're always being invited into these conversations to help improve things. And so you have the power to set the stage for what we want to do and what we expect to happen. And so if as students, you are seeing gaps in your training, you can definitely say, hey, I was in osmosis, you know, I got access to this new software and, you know, I'm getting to practice clinical cases and it personally helped me because we didn't have a lot of cases in our, you know, clinical orientation. I forget what that class was called. Cyan or Iman, do y'all remember? It's the small group classes. I forget what it's called.
Clinical reasoning.
Clinical reasoning. Yes, thank you, ma'am. Yes, clinical reasoning. We would basically do these case-based scenarios, and then we would, after that class, we would write, you know, soap notes about those presentations. But uh, going into a case. Let's just choose. I love pediatrics. Let's just choose Aaliyah. So, I'm just gonna make this bigger. All right. So Aaliyah, it gives you the case. She's a 10-year-old girl who is normally energetic and outgoing, but she has been feeling poorly for 10 days, and achiness and tiredness, and today she has a fever. Okay. So these are our outcomes. You can read them, but I'm not going to spend a lot of time on them. So, this is her telling us how she feels. She feels achy. Again, she's a 10-year-old girl who attends at a nearby elementary. Her favorite subject is English. She's learning to play the trumpet for her school band. She's normally energetic and outgoing, but she's been feeling poorly for 10 days with achiness and tiredness. And so, really setting the tone for, the fact that she's a very energetic girl. She's involved in things at school. She does go to a nearby elementary school. So that's even important because sometimes you'll get updates saying, hey, there's an outbreak of measles, there's this going on. And that's important for us to know because, like, oh, if we know these things are happening in the local area, we can definitely kind of put them on our differential. So she says, I'm feeling very tired. She has little energy. She's not interested in eating meals. She told her mother that she felt achy and she had a pain in the back of her legs that woke her up at night. Um, she complains of a sore throat and a headache when waking up, but these are relieved by Tylenol. And her mother has taken her temperature each day, and today was the first day she actually had a fever. So it seems like Aaliyah has she has some very non-constitutional symptoms, very vague, but now all of a sudden, she's having this fever. So your gear should be turning as far as what we think could be going on. Like maybe she has a viral infection, but it could be bacterials with her having a later onset of fevers. So now she's been shivering. So after she developed the fever today, Aaliyah asked for a blanket and said that she felt cold. Even though it is August, her mother noticed she was shivering despite her elevated body temp. She's not had much of an appetite. She vomited. She has not vomited or had diarrhea, which are pretty pretty high on the differential if you are suspecting a more viral prodrome. Her mother had not noticed any weight loss or night sweats. She also is not coughing. And so that is another thing that helps kind of set the stage for like if we think it's like a strep throat, if she was having a sore throat or something else. So then it takes you to her chart. It gives you, kind of those basic things that you would get from your team that's maybe helping you take care of a patient. So you'll get her respirations, her pulse ox, her blood pressure, her heartbeat, and then her temp. So definitely has a fever. And then it kind of gives you a recap of she's been unwell for 7 days. This is just your HPI, your pertinent positives and negatives, but also that past medical history. She's a kid, but we definitely care about vaccinations. Does she snore? That's important for like sleep apnea, but also like some kids have huge adenoids and tonsils, and so that could be a source of infection for a lot of them. Um, Social history. Is anyone in the home sick? Who does she live with? Where does she go to school? Family history. Does her parents smoke? Is really important for like if she was having more shortness of breath symptoms, and then any drug treatments. She did try the Tylenol, and who said it helped some. So these are all good things to know. So your mind should now start to be wondering, like, okay, what do I think is going on? How do I want to present this now case to the provider? Uh, so this platform actually allows you to record your response. You can record it, which I'm not going to record it here, but if I did, it would give me it. I tried to do this when I practiced last night, but it's something I think when I'm like in a platform of sharing my screen, it doesn't always play nice. But you can also type your response. But why type when you need to be practicing on your speech? So you can record it. It gives you a 5 minute window and you can listen to your recording. You can say, oh, is it following that SOAP format? Um, but next, you can just submit your response. And mine wasn't long enough, but it typically gives me feedback and says, you definitely did this or you definitely did that. But here is an example of one that is pretty concise and straight to, aligns with what we are expecting. So it was an overall quick one liner. A 10-year-old girl presented with a 7-day history of fatigue and sleeping more than usual. That's our one liner. Our expectation is okay, like what's going on? Does she have a fever? She's sick? Did she have sick contacts or whatever? We want to know her symptomology. And so she developed fever associated with shivering spells this morning. She has had multiple other complaints, including sore throat, headache, decreased appetite, and pain in her legs and back that disturb her sleep at night. So now, okay, well, what do you think is going on? So do you think this part is great, but for me as a person that's really trying to develop my skill set, I start to think of differences before I start choosing things. And so I would just say, oh, well, it could be that she has a bacterial, infection of some sort. Maybe it was strep throat, or maybe she had a viral infection. And a lot of kids start to develop these symptoms of like muscle pain and aches, which is very common with the flu. Um, so you can kind of get your gears turning and you can choose things. So I'm just going to generally pick some things with her having fatigue, which is her big complaint here, and sleeping more than usual. So she's low energy. I always like, okay, what are the things I cannot miss? Like if she's low energy, maybe anemia, because like if, kids they really aren't good historians as far as being able to really speak to like these buzzwords that we learn. So I'm just going to keep that as one that I don't want to miss. But, it could also, again, be continue to my second. And then I'm going to pick influenza. And then maybe I'm going to pick mumps, even though it's probably not likely. She is vaccinated, but it could happen. But with her age range, not likely. But anemia, influenza, mumps. So I submit my differentials and it gives me feedback. It's saying, well, no, it's going to ask me for my physical exam next. So what do I want to do? So with her having fatigue, I want to listen to her heart, maybe listen to her belly. Her general appearance is always important. Does she look pale? Some of those physical exam findings that you're really wanting to see. Um, and maybe respiratory. Just picking a few things. It's going to give you feedback about everything you pick. So, uh, it's going to give us the information that we asked for. So her cardiac exam, she has a 2 out of 6 systolic ejection murmur, heard loudest over the lower left sternal border without radiation. So I love to use this information to like practice my knowledge of like murmurs and defects. What are the most common ones? And just trying to really kind of keep that information, up to date in my mind. So looking at her belly, she has a scaphoid abdomen. The wall moves with respiration. You can palpate the liver edge. The spleen is palpable. So should the spleen be palpable in adults? Maybe, maybe not. No, it should not. So that's definitely something that we need to, be concerned about. But you have to know why something is important, or why do I care that I could palpate the spleen or not palpate the spleen? As a student, always be knowing or asking those questions if you don't automatically know, because people assume you know that. So there's that. How does she look? She looks unwell. She's on the table. She looks like she is ready to cry. She's pale, but there's no cyanosis or jaundice. And then looking at her skin, she has multiple petechiae, scattered healing papules. So, maybe there's like a hemophilic or hematologic issue here at play with her having some of these very non-specific symptoms of just, pallor and just the petechiae. But that's why hearing her hearing her um story, and then also hearing what her, or seeing what her symptoms are on physical exam, it all should go back to possibly support your differential. Maybe you add things, maybe you remove things. In real life you can always add another one, but in this case we cannot. But which investigation tools are next? So now, if I'm definitely thinking that she has anemia, I'm definitely going to get like a CBC. So I might want to do that. Maybe get her electrolytes because maybe she is having some electrolytes imbalances that can cause this fatigue. But what if I thought she had mumps, I would get that. She's 10 years old. So we know monospot is really big with like the cytomegalovirus, Epstein-Barr, helping us rule that out when they have an enlarged spleen because it is palpable. So you learn these things and now you learn how to apply them. Because I thought she had the flu, I would get that. So those are just a few things. And then I submit it for review and I perform all those things. And it's going to give me some information based off of my exams. So her white count was a little low, 3.2. Her hemoglobin is 20, so she definitely has some anemia going on here. Flu was negative. I knew those things would be negative, but they were on my differential, but I wanted to support it. And then her electrolytes, her BUN, all that stuff. So you really learn how to work on your speed in this program. So then you just choose your diagnosis. Um, they usually put your differentials on there, and then if you didn't choose the right one, they'll put the right one on there. So there's a chance for you to still get it right. But I'm gonna choose anemia. Um, and then now our treatment. So this is, continue to take it a step further. So with her having anemia, I definitely want to admit her um, because with her blood counts being low, she could go either way. Maybe some iron therapy. My favorite answer of consulting hematology isn't on here, so I have to do something. This med looks familiar. Maybe I give that, but you would select what you would want to do, maybe a nutritional assessment, give them some education, Primaquine or the chloroquine. I can't remember which one, but this is also still a way of studying. So thank you, Sabrina. This is, we've done all the things. You're now complete. Now here's your feedback. Up, suboptimal, didn't do the best. It was actually a diagnosis of leukemia. But maybe I didn't ask the right questions. Maybe I just didn't know what to look for. And so these are really great assessments for me to kind of go through and say, oh, this is not one of our top three. You chose this, but this is why. We can see why you chose it, but in contrast, this is actually well tolerated in kids, and they really make it very practical for you. So I love that. And it just kind of tells you like why you didn't choose or why they didn't choose these things, even though you did. But meningitis should have possibly been one because she did complain of headache. Sepsis for sure because of the history of fever and chills. Those are big things that we can't miss. But as students, we don't know this. And so this is a really great tool. And so our exam outcomes. So yeah, we agree with your physical exam, but we would have also done this. And you can open these things up to see like what we're specifically checking for. So that's really great. Your investigation only got one right, which was the CBC. We're looking for signs because she had signs of pallor. That is, helping kind of confirm my suspicion of what I thought was anemia, but it's actually leukemia. Um, but they said they would have not necessarily ordered these because they weren't necessarily indicated at the time because, my thought process wasn't in line with this case. Learning point, blood cultures. Fever is always like anytime there's a fever, we have to investigate it. And I just didn't. And I wanted to just show that as like a learning tool. Um, Thick and thin blood smears, that'll allow us to see. We've done that in class, um, to show like what blasts are actually on the blood smear. But overall, the diagnosis, like you chose this because maybe, the hemoglobin, like what were you thinking about when you selected this option? But here's a better choice. And so it's really it's really nice because it packages it in a way where it's like, okay, I know you chose the wrong answer, and we kind of can understand why, but here's a better reason. Here's a better choice, and this is why. And then hospital admission, like, why are you doing these interventions? Like, what are we looking for? This is not necessary, and then other things that they would have done. So this is one of my favorite tools to use. I've used it to help develop my personal statements when I'm presenting cases, but also while I'm out on clinical rotations and I'm not always getting feedback. This is a way for me to learn how to do things a little bit more efficiently and more in line with a clinical thought process. So I know I'm a little over time, but I definitely want to open the floor for questions. And then, if you don't mind, I would also like to have everyone kind of come off screen so I can get a picture to post on the Osmosis platform to let them know about this presentation today. I'm
So
actually going to go ahead and stop recording as well.
at what point did you know like osmosis would work for you when you were in your didactic year?